my great privilege to introduce Dr. Marita Thompson. She is the Division Chair of Pediatric Critical Care here at Dell Children's. She's had a long and illustrious career in critical care. It began as a fellow at UT Southwestern, where she continued her career there as an attending for about 16 years before transitioning over to Children's Mercy in Kansas City for a handful of years. And we've recently gained her to our great fortune here at Dell Children's, where she currently leads our critical care division. And she's here to talk to us about ARDS and pediatric oncology.
I have to admit that I actually really struggled with this talk because intensivists are known for really loving pathophysiology and going into it in minute detail. So I really chose, I'm going to show you pathophysiology. I'm going to try not to have you glaze over, but kind of do a little bit of a historical perspective of where we've gone with ARDS. And I think you're going to see that it fits right in with the talk we just had and where we're going. And at the end, I'm going to put a little bit about oncology and transplant patients, which really I think it's going to be old hat for you guys, but for those, and I know that I have some critical care colleagues watching online because they're up in the ICU, is things that we need to think about from the ICU perspective. So I have no disclosures, but I want to talk a little bit about what do we in ICU world think about, what is ARDS, what do we think about it, and where are we going with it, and how does that relate to oncology patients? So ARDS, it's a pretty vague thing. It's an acute respiratory failure that's considered heterogeneous, severe, and life-threatening. That's it. That's how it's defined. It was first described in 1967 by Ashbaugh et al., who found 12 patients out of a group of 272 on ventilators, of which I want you to note that even though they described it, original title was adult, not acute, but it was adult, because they were comparing it to the preterm newborn hyaline membrane disease. But just note that 5 of those 12 patients were under 20 years of age. And so it was really described as patients with severe hypoxemia. They had poor lung compliance. To those in the not in the ICU world, your lungs are stiff. It's hard to get your lungs to expand, whether you're on the ventilator or whether you're just breathing yourself. And then diffuse bilateral infiltrates. So you can see in this screen where you just start with just slight haziness. You know, you can see the bases are a little bit hazy. And then over time, you progress, and ultimately, you get this bilateral whiteout of your lungs. I look at that and I go, okay, what is it? It's pretty crude. I don't really know what that is, but I know that I have sick lungs just by the fact that they're becoming opacified. So of these 12 patients that they originally described, 7 of them died. Some of them died, 5 died, quote unquote, early, and 2 died late. And when you think about them, they said all the lungs were heavy, reddish colors. Now, when I think of lungs, healthy lungs to me is, excuse me, this is me doing my mom part. I've gone to the market, I bought a brand new sponge, I rip it out of the package. It is soft, pliable, lots of nice air cells. Open. That's what I want the lungs to be. Soft, delicate, very pliable. But what they were seeing, that were lungs that I dropped in the sink, filled with water. They're sodden, they're heavy, they're hyperemic. They're not working. You cannot exchange gas when your lungs are heavy like that. They said it looked like liver, okay? That's not what you want in your lungs. And then when they went on pathology, they were hyperemic, their capillaries were engorged and dilated. They had what was described as atelectasis. What is atelectasis? That's a really vague term. Think of that nice sponge, all those air cells, right? When they're never supposed to lose all the gas in them. They're always supposed to open and close nicely. They're not supposed to be huge. They're not supposed to be tiny. They're just supposed to be nice and in that medium size. But if those air sacs are no longer filled with air, they're filled with other things, fluid, cells, inflammation, bacteria. They are now non-functioning, and they look atelectatic or opacified. So when they finally, on those late patients, those lungs were not only diffusely inflamed, but they were fibrotic, they were scarring, they were stiff. So since this original description, we have been struggling in the critical care community to actually define what is ARDS. So we've had multiple definitions. These are adult definitions that I show the first two, but really it's an acute onset, usually described within 7 days. Imaging, back to chest x-rays, bilateral hazy infiltrates, no more descriptive than that. We look at how well we are oxygenating patients, so we have various indices that we follow, and then we can use those to try and grade how severe your ARDS is. And then for us, how we use the ventilator, so when end pressure, remember I talked to you about those alveoli, we don't want them to collapse. Part of the measures that we keep our alveoli open is our vocal cords, that at the end expiration, we close our vocal cords, that keeps gas in our alveoli. If I put an endotracheal tube past your vocal cords, you're no longer closing your close, because I put an obstruction in there. So we put pressure on our ventilators to try and mimic what your vocal cords are doing, and that is PEEP. Looking at the ventilator pressure is not excessive, that's as well. The other piece that we're looking at is to say, this is not lung disease that stemmed from heart failure, okay? We're gonna talk about heart failure in our next talk, but this is not because the left side of the heart is not functioning and you have back pressure into the lungs, okay? Different than Dr. Danvoy talked about pulmonary hypertension. This is left-sided heart failure. Finally, from the POLICI group, which is a pediatric consortium, we now actually are getting pediatric definitions, very similar, but some things are specifically different. Again, we are looking at children. We are trying to separate this from children, especially the preterm children that have chronic lung disease. It's again 7 days with some insult. Respiratory failure that's not explained by cardiac disease or fluid overload, which is a crucial component in critical care. And then the other really important piece is that not only are they looking at indices on the ventilator, we're looking at indices on non-invasive ventilation now, because we do a lot more non-invasive ventilation than we did 15, 20 years ago. So this is an adult listing of mortality in ARDS, and notice that it's from 1981 to 2004. And I didn't put later on because the mortality is the same. It really hasn't changed. And so when you look whether this is a retrospective review looking at a whole series of observational or randomized control trials, and mortality in the early days when it was first described was about 80%. And we have gotten mortality down to somewhere between 30 to 40%, but we've plateaued. Okay, that's most of the time that is around where our mortality is, unfortunately. Even if you go and look at the pediatric section, so again, this POLICI group that went and they looked at a lot of patients. A lot of patients, let me rephrase from a pediatric perspective, 23,000. And it broke down, these were critically ill patients that ended up with around 700 patients with some form of ARDS. And they even looked at the patients that were chronically ventilated, non-invasively ventilated. They broke it down into mild ARDS, moderate, and severe. And even in the ones that were chronically ventilated, 7% mortality, and the most severe, again, had a mortality similar to the adults at 32%. So what's causing ARDS? Well, look at this slide. It's a multitude of things, and that's part of the problem. So typically, we break it down into a pulmonary cause, or a direct cause, and a non-pulmonary cause, non-direct. And so when you start looking and breaking this down, so the biggest group is this blue circle underneath, and that would be sepsis. So some form of infection, and then trying to break it down into, is that bacterial, is that viral? We have COVID, of course, in there. We have any various pneumonias, One group that is increasing is this yellow circle, the immunocompromised, is becoming a bigger group that we're really having to learn about in the pediatric critical care. And then this other schematic, just trying to give you a sense that it can be a whole variety of non-pulmonary etiologies. We tend to forget about long bone fractures. I had a patient in the ICU last week who had a femur fracture, came in with healthy-looking lungs the next morning after was on a ventilator for a different reason. The lungs were fully opacified. Was it fluid overload? Was it a fat emboli from a femur fracture? Things that we don't normally, automatically say your lungs are going to get sick. But we think that the lungs kind of act as a barometer. Anything happens diffusely, you have a chance of your lungs getting sick. So here's the dilemma. We really have no true diagnostic test to define it. We are doing it based on these vague clinical criteria, and we know that the lung is really sensitive to both local and distal insults. And part of my dilemma is we treat ARDS the same way for every single patient, and maybe that's not the right answer. So in the last 20 years, since I showed you that mortality slide, we in the critical care population have been trying to hone down and figure out what is the etiology. And so I'm going to show you how things are changing a little bit. First, let me take you back into, we normally divide ARDS into 3 phases. It's a typo, it should be the exudative phase. And really that's what we see in the first week. And you start losing, nice air cells are disappearing. You see things are broadening and opening up. You can see this arrow shows a hyaline membrane forming. And then you get into this proliferative phase. Does that look like lung? It doesn't look like lung. There's no air cells in there. There's no way to get any gas exchange. You can see how the lungs are really not able to function. And then you start getting the scarring and all the myofibrils, and it gets very fibrotic. Trying to break it down on a pathology level, so the pathologists have about 50% of the patients they think have this diffuse alveolar injury, where you again, with this slide right here, the first one, A, showing you this is that nice honeycomb that we want the lungs to look at. And I want you to see you have this nice thin layer in between all of those air sacs, those alveoli. And we're going to focus on that layer in just a minute. And then you start getting breaking down of the layer, you start getting you get a lot of protein and inflammatory cells moving into those air spaces. You start layering on the edge of the alveoli so they stop functioning. You work your way to, you can see you start getting a lot of inflammation in there. And then finally, you start getting fibrosis and you get thickening of that interstitium. So I know, don't get sick, me showing you the alveoli. The ICU docs, we love the alveoli, but I think it's pretty, when you go through it, it makes a lot of sense. So your lungs work our way down into, let's take this as one single alveoli. We're going to look on the healthy side and then the injured side. And on the healthy side, you see coming in from the airway into the alveoli, we have these nice columnar cells. If you were up close, you could see they have cilia on them, and they are moving mucus and cleaning out the alveoli constantly. And then we have these super thin type 1 cells. Let's see if I can get that. What's that? I can just pretend to point. I'm not tall enough. So where it says, where it really just looks like a thin yellow layer, that's a type 1 pneumocyst. And along next to it, you have a type 2. In each alveoli, you're mostly type 1s with just a few type 2s. What are the type 1's goal? Their goal is to provide tight junctions and to provide a very thin layer because that's what your gas has to diffuse through. Whereas your type 2s, they repair, they regenerate. Type 1s, they produce surfactant. Okay? And then we have this really thin interstitium, and next to it is a capillary. Okay, that capillary is thick enough to get 1 red cells through it, but it's nice and smooth. You don't have any clotting. It's just very thin, delicate layer that you can get gas exchange through. And then what happens when we get infected, when we get any insult? We start breaking down those layers so that the type 1 cells, they pull apart. They start getting necrotic, maybe they get apoptotic, and then you start, because there are no junctions, you start moving fluid from the interstitium, you start getting proteins, you start getting inflammatory cells. All of a sudden, you have this big inflammatory milieu within what's supposed to be filled with gas. It's now filled with proteinaceous thick material, which forms what we call the hyaline membrane in there. Alongside with that, you get movement into the interstitium because you also get damage to the endothelial cell. And so you get red cells can leak in there, white cells, more again, fluid shifts, and all of a sudden that nice, thin, delicate layer is thick. And you can't get gas exchange through there. Oxygen does not diffuse well through thick. It needs to go through very thin layers. So we know we have this damage, but the question is what causes it and what can we do to stop it? So we've got 50 years of ARDS research under our belt. Okay, but I told you, we've still plateaued our mortality. So what do we know? Well, we know that we in the ICU can destroy your lungs with the ventilator. We have done it too many times. We have learned, you'll hear us, we have these terms, we'll tolerate you being hypoxic, we'll tolerate low saturations, we'll tolerate high CO2s, as long as your kidneys are still working. We have learned to just sit on our hands a little bit and not try and make things perfect. And so that's helped us a lot, but it hasn't helped us all the way. We've also learned that when I started fellowship, it was okay to make my patients huge and swollen. And I said, yeah, it's kind of unsightly, but it's fine. It's not fine, and it increases our mortalities and morbidity significantly. We use blood products better. We used to try and keep your hemoglobin really high. Through multiple studies, we've learned that probably is not the right answer. We can prevent trolley now. So we have a lot of things that have helped us with what is hurting our lungs. But again, we are not really getting there. So now we're noticing that as we brought down these injuries, other groups are starting to pop up more. One of those being patients that have gotten chemotherapy, one of those being patients that are still immunosuppressed, not necessarily from the oncology world. And so we're really trying to shift and say, what is it about these patients that's making their lungs so sick? So as we start looking, and again, we're going back to that alveoli, and we are looking at that epithelium, and then we're looking at the endothelium. And we know, again, we have damage to the type 1 pneumocystis. We have damage to nice, smooth layers. So this slide really nicely shows you what the normal should be on the epithelial level, and the normal should be on the endothelial level, and then the damages. And they're kind of really similar. You start damaging the smooth layers, the glycocalyx on both of them. Once you start damaging the glycocalyx, the cells start separating, and then you get migration, inflammatory cells, red cells, fluid, proteinaceous material, and all of a sudden you've set yourself up for this huge inflammatory response. And again, as we start seeing inflammation go haywire, it's really hard to pull it back into control. So we've been working towards how can we recognize the damage early, how can we modulate the damage, and what should we target? So I think one of the big struggles is what should we target? So I put this slide here not for you to say, okay, these are so many things involved, but to try and say, which things do we go after to try and figure out that they're part of the etiology that we can mitigate. And so now we've worked our way, so the latest work is now really trying to separate what's damaging the epithelium, what's damaging the endothelium, what's inflammation going crazy, and so trying to pick modulators from each of those areas that we can now investigate. Not only are we trying to choose from each of those areas on the cell types, but also in these different phases of ARDS, so we can also try and figure out where you are in your disease progression. So you guys probably don't know what the ARDSnet is. The ARDSnet is a really huge consortium of adult critical care facilities pulmonologists that for 30, 40 years have been doing huge studies investigating ARDS. We look at them pretty heavily in the pediatric world because they have a lot bigger numbers than we do, and they can do a lot more studies. And they were the areas that really showed that ventilator-induced lung injury, fluid overload, and then we've replicated that in the pediatric world. But so they took some of their huge studies, and they said, we've got leftover serum. Some of them have leftover bronchoalveolar lavage fluid, and they said, let's try and go back and look at these endothelial, epithelial, inflammatory, and just go see if we could find any patterns. And what they found is looking at inflammatory markers, IL-6, IL-S, soluble TNF receptor 1. They've looked at vascular epithelial markers. They looked at coagulation markers. And they surprisingly found some what they call hyperinflammatory markers versus hypoinflammatory markers. So if you look in this, this is a Kaplan-Meier, and on the x-axis you have days 0 to 25 and survival on the y-axis. And it doesn't really matter, these are old studies that they went and pulled the data from, that they went and looked at these profiles, and they found that the patients that had the hyperinflammatory, they had worse mortality. Okay, so it's really observational going back and looking at that retrospectively, but there are large patient populations. And so it may prove to be something that we can target. Starting to look at it in the pediatric world, and we have seen that some of the hypoinflammatory phenotypes also follow for our patients, but not as tightly. So we kind of question in the pediatric world, you know, we have different ages, we have different lung diseases underlying, so maybe there's more to it. But at least it's giving us a way to stop just doing generic kind of critical care medicine, but to be more phenotypic specific. So I don't think we've made headway. We're not at 80%, but we've plateaued. We really know our ventilators are important, and we spent a lot of time learning how to use them well. But we're looking at the final common pathway of a lot of triggers. And so our main focus right now is to go backwards and try and figure out what's triggering our patients and what we can do to mitigate or have specific therapies. So shift a little bit and look at the oncologic population. And so we know that at least 25% of the transplant patients have pulmonary problems. Somewhere around 10% of them are needing invasive mechanical ventilation. That's not accounting for how many are on non-invasive ventilation, including high-flow nasal cannula, which is very commonly used. And historically, oncology patients are terrified of the ICU. They don't want to come to us. You know, they associate the ICU with death, horrible mortality, and so do anything but come to the ICU. And there was time when it was thought to be fetal care by that stage, and so patients weren't given aggressive care. But more recently, we're seeing that if we intervene and we are a really good multidisciplinary team, that our interventions improve their survival. I did find this was very interesting. This is Rowan et al. Has published quite a bit of work, and one of their publications was on non-invasive ventilation, which we actually really love in the pediatric world. We use it quite a bit. But they associated of their patients, their transplant patients that went on non-invasive, more than 50% of it failed that therapy. Scary, a little more than 10% arrested with intubation, which to me says we probably need to be intervening a little earlier and getting them and not be terrified of invasive mechanical ventilation. And then 3% arrested as well. So again, put those two together, it's about 15%. So this is from Janet Hume and her group. She worked with a transplant team up in Minnesota. She's an intensivist. But she just went back and looked at survival of patients that needed critical care, and the survival is improving. You know, and this is still now older data, but it just supports that we need to be aggressive in working with our patients. Pediatric, looking at breaking this down, the Polisi group looking at formal pediatric ARDS definitions in the transplant population. And if you can see in this third column is survival. And in the patients with mild, moderate, and severe survival, survival in the, it's backwards, in the mild or death was 14%, but up to 30% in the severe ARDS. Okay, now one of the things that they just looked at survival, they didn't really look at what put your patients in the ICU and gave them respiratory failure. So the next things I'm going to show you, you guys know, this is your world. You think about this all the time, but this is not the world that the critical care docs think, and this is the world where we need to share overlap. So historically, what did we worry about? We worried about the time that they were getting conditioned and their immune system was not functional, and in our mind was, you've engrafted now. Okay, you're good. Your immune system's good. Because we really didn't understand all the changes that were happening with your immune system. And so we've had to learn that you have to not only look at the pre-engraftment, but you've got to go all the way out. You've got to think about where are you during and where are you in your disease, and what do we need to think about depending on where you are, and what kind of transplant are you? How did you get conditioned? All of those details, which it's kind of like the nuances for me with the ventilator. These are the nuances for you guys, but we have to share this knowledge. And so for the intensivists, we're not very good at thinking about all the infectious etiologies. We know we have to worry about infection, but really being able to hone it down a little bit and worry about it in a specific time frame. And then the other piece is there are many different components of non-infectious lung disease that give you ARDS. Now, I would argue over time we're probably going to figure out, it's all again going back to how are you damaging the epithelium and how are you damaging the endothelium and what treatments we can do to protect them. But all of these, we just heard about how we can develop pulmonary hypertension, which we think about all the time. But I'm going to take you through just how much things overlap with our standard examination of ARDS. Now, again, this is for the non-transplant people to really, again, remember, if you're looking on this little tiny kinetic recovery, that's up to a year, to remember that the immune system is not fully functional for a long, long time. And so you can have a lot of unrecognized consequences that if we're not working together with the transplant team well, we don't even know to think about, okay? And then to recognize, well, these are risk factors for BSI, but it all reflects together that all the components that are impacting what's going to happen to our patient. And I think you can just change that risk factors for BSIs to risk factors for lung disease. So what's the timeline? Well, again, if you look on this, this is up to a year, but you've got to be thinking about different organisms from an infectious perspective, and you've got to work to rule those out before you start even progressing towards the non-infectious etiologies. So we need a really high index of suspicion. We don't have a great test to identify it. It's more based on clinical exams. I think that pre-pulmonary function testing and pulmonary function testing frequently may help us identify things at a much earlier age so that we could intervene faster. Bronchoscopy is always, we're really scared of bronchoscopy. We think your lungs are a little sick, but I'm going to push you over. If I have to intubate you, do a bronch, put some fluid down there. But on the other hand, if we can get an infectious etiology that we can treat or go after, we're probably going to help you. And most of the studies are showing that a very small percentage of patients that are not intubated pre-bronch are needing intubation post-bronch. The other big question mark is always, should we be doing biopsies on these patients early? You know, that's a really hard one because you don't want to make your patient push over and then end up with really severe ARDS. But sometimes it might help us identify what's going on. So hopefully, with time, we'll be able to get better biomarkers. serum. Preferably, I think the serum rather than bronchoscopy, because we get blood pretty frequently, but that will help us identify what's going on. So if you look at just two of them, idiopathic pneumonia syndrome and diffuse alveolar hemorrhage, we'll see that they show a lot of overlap, and they show a lot of overlap with some of the other things I showed you. So idiopathic pneumonia syndrome, as you guys know, up to 12% of transplant patients develop this. Again, it's a very vague diagnosis. Diffuse alveolar injury, pneumonia. You have to prove that there's not an active infection, but it has a really high mortality. So what's triggering it? What's making you sick? Maybe you can get a biopsy, but we don't actually know very well. So, but if you go and start looking at it from patient perspective and then from some animal models, primarily mouse models, we're seeing infiltration with macrophages, lymphocytes, epithelial cell. You're seeing a lot of infiltrates in your vascular beds around the vascular. Again, pulmonary endothelial injury. It's coming right back at us. So maybe it's, again, very similar triggers. And they're noticing cytokines that are elevated, IL-6, IL-8, and TNF. That was what we saw in this inflammatory, non-inflammatory model from the adult ARDS studies. So very similar again. And so there's, how do you treat it? Some people are doing work to see if we can block TNF and if that mitigates the injury. So I thought these biopsy data were pretty striking to see what's happening to your capillaries and the endothelium, and you can see they're pretty much gone. The lumens are gone because there is so much activation and injury in the endothelial beds. And you can see easily, why is somebody going to manifest pulmonary hypertension? Well, if there's no vessels for blood to go through, it's going to manifest with right heart failure and pulmonary hypertension. So, as we heard in the last talk, ST2 has been noted to be elevated, as well as tumor necrosis factor receptor 1. And so treatment, steroids, and maybe we'll find with TNF blocking, and there are several studies that are ongoing to answer that question. If you shift to alveolar hemorrhage, it's a subset. Again, a really vague definition. Shortness of breath, infiltrates on X-ray, progressively bloodier alveolar fluid. I don't really know what that means. You know, I see more and more blood, but it's pretty vague. You have a very ground glass appearance on chest CT. We see that all the time with any infections when we're checking for ARDS, and they may have an intralobular, what they call crazy paving appearance. Mortality can be terrible, 100% in some studies. And again, you're getting multi-organ failure, but we don't have a clear diagnostic marker. What's the working diagnosis? Inflammation, cytokine release, which is the common pathway that we're seeing for all of these. Now, I love this schematic because I think we can put this ultimately to a lot of the things we're seeing where they're really trying to figure out what's triggering your epithelial injury, and then getting to inflammation, and then working our way to what's happening to your cytokine response, and it's dysregulated, and then finally what that injury is doing to the endothelial cell, and where can we start intervening and stopping this injury. So these are very phenotypically similar syndromes. The cytokine system seems to be very dysregulated. But what are we doing? We're going back to our same maneuvers. We're using lung protective mechanisms with our ventilator. We're trying to avoid fluid overload. We're trying to not give excessive blood products. But we're really not going specifically at what is the etiology. Yes, we do use some inhaled TXA and things like that to help with bleeding, but it's really symptom treatment. So hopefully corticosteroids and TNF blockade may be specific. I'm not a big lover of corticosteroids. Yes, I think they're wonderful, and we throw them at you all the time, but they're kind of like a big shotgun of going at things, and I don't know specifically what I'm treating. So when you start breaking down all of these various lung diseases, the goal in my mind is that we can break them down into where the actual injury is happening so that we can focus therapy. Again, from the POLICI, this is in the Pediatric Critical Care Network. They're really trying to take our pediatric patients and not just break them down, not just have one big umbrella, but try and break them down into phenotypes and then subphenotypes and then endotypes so that ultimately we can have more precision therapy. And that's what I think we need to do with our transplant and oncology patients as well. And so when you think of ARDS, hypoxemia, diffuse infiltrates, it's a really heterogeneous diagnosis that we throw into one basket. We know that we have to control how we use the ventilator, how we control fluids, and how we control blood products. But we really are kind of stuck kind of in the old days, and we need more precision medicine to really define and control this disease. I think that if we really work to define infectious etiologies, that also will be helpful, and we can't be scared of invasive things like bronchoscopy to define what's happening. So the biggest key to me is we really need multidisciplinary involvement and talking to each other daily to understand from the various perspectives that we have. That's what I got. Thank you.